Hello, and welcome to the Fire Chief Podcast, the only podcast dedicated to the Chief Medical Officer. I'm your host, Lee Scheinbart, and this podcast features stories and wisdom from the best CMOs in healthcare. These leaders face the toughest challenges in healthcare right now, and they will share with you their insights about how they do that. Today, our guest is Dr. Chris Chisholm, the Chief Medical Officer of the Providence, Swedish Central Service Area in Seattle, Washington. Dr. Chisholm was raised in Escondido, California, just north of San Diego, and he attended Bethel University in St. Paul, Minnesota, where he earned his undergraduate degree before enrolling at St. Louis University in Missouri, where he earned his medical degree. From there, Chris went to fulfill his emergency medicine residency at the Navy Medical Center in San Diego, California, and later a fellowship in cardiovascular emergencies at Stanford University in Palo Alto. Dr. Chisholm also has earned a master's in health service research at Stanford, along with an MBA from the University of Tennessee, and he is a certified physician executive as bestowed by the American Association for Physician Leadership. Chris, welcome to the show.
Yeah, thanks. I appreciate it. And thanks for listing out all those titles, because I want to at least appear smart before I talk and ruin it.
Hey, we can add more just for fun if you want to. Next time.
Well, the funny thing is I went to a conference one time and I didn't know any better, but I put down all the different things on that. And so it all ended up on my badge, and I was the only one. Everybody else had like Chris or Bob or Jenny. And I'm like,
So before we get too far, let's establish a couple more things. We first met at a meeting in San Diego, I believe a few years ago, and that you were new to the CMO role at that time when you and I first met face-to-face. Does that sound right to you?
New to it as a civilian. I had been doing it in the Navy for 5 years.
But did it not feel like a different environment, though, than the Navy, or similar?
No, I think they're similar. I mean, some of the finances are different, but as far as the fires and the personalities, I think that's universal.
That is true. I've heard that from many chief medical officers. So you must be doing okay. And now here you are, a guest on the show. So you've lived to tell your story, and we'll get to your story and your journey in just a minute. But we do have a couple of mutual friends and acquaintances, some within the Providence system and some outside. And in fact, we were talking earlier, you were just in Dallas and met with some of our CMO friends like Dr. Rex Hoffman.
Yep. Yeah.
How was
Marcus
the meeting?
Evans, yeah. It was good. I thought it was good. I think that meeting is definitely a vendor strong meeting. Like, you're there for vendor interaction. But I thought the discussions and the round tables were really good. And, it's funny because I gave a talk, and then everybody's like, well, how did it go? I'm like, I don't know. Nobody walks up to you after a talk and says, you know what, you wasted an hour of my life that I'll never get back. So I don't know. I guess it went okay, but I enjoyed it.
So you're right. People are a little conflict averse, especially physicians, but they'll troll you on social media and they'll be like, that was awful. Don't ever that. So it'll come back to you. You probably did a great job. So, did you make any new CMO friends while you were out there?
I met a few folks. Really, though, it was kind of touching base with some of the folks that I had already known and were actually in our system, and so Rex, who's down South Providence.
It's always good to meet other people in our role. That's, I think, the origin of this podcast is because we don't have a good way of connecting with each other and hearing some of the things about our role and what we might learn from each other. And so with that, let's tell our listeners a little bit about your journey to becoming a chief medical officer. And you take us back to the cardiovascular emergencies fellowship. And from there, you journeyed to become a chief medical officer. So tell us about that.
Yeah, no, so in the Navy, if you want to make rank, in the Navy, you want to make rank. And I wanted to be a Navy captain, which is a 06, and you got to take on different administrative jobs at some point if you want to do it. And I'm an ER doc, so it was funny because I talked to my ER administrators, and I'm like, hey, what's the next big ER job coming up? They're like, doesn't look good. Looks like you're going to have to go find something else in the Navy to do to make captain. I'm like, well, that's a great pep talk. so from that, I knew some folks that were in the primary care business, and so we had branch medical clinics in San Diego, and I asked and I ran to see if I could be the director for one of our branch medical dental clinics, and lo and behold, they were willing to let an ER doctor do that. So I ran one medical dental clinic, and then we ended up doing really well. And so I ended up being the director for all the medical dental clinics in San Diego. And then that's how I kind of got into the admin part. It was kind of a bug. You don't like most doctors don't, I don't know. Not all of us go into medical school thinking we're going to be administrators, and you don't know you like it until you do it. And then you're like, wait a minute, this isn't so. I used to think these people were the problem. And then you're like, well, wait, I can do this better because they are the problem and I can solve it. And then it's like Darth Vader, right? Then like one day you look down at your hand, you're like, it's mechanical.
That is so true. And I'm at a medical school these days, having survived my years as a chief medical officer. And students do ask me about that life, but to your point, none of them actually want to be in medical school in order to become like us, but they're open to it. So at least we're creating a new generation of problem solvers and mechanical handed Darth Vader people. So,
but I think it's a good thing though, Lee,
yes.
because I think, you don't want somebody whose whole goal is to not be in medicine, right? You want somebody whose first love is medicine, and then their second love is, I could do this, and I think I can make it better. You want a bit of a reluctant leader, right? You want somebody who's not dying to get to the C-suite, but when they get there, they still have a heart for what they're doing, and I think that's key.
I love the notion that you just wanted to make rank, but you were darn good in the clinic, so no good deed goes unpunished, and off you were to the races. So continue how it evolved and how you ended up at Providence.
So then from there, I ended up being the next job, and so the Navy's great. Like that, if you know what you get for winning the Python contest, you get more pie. So I was sent to be the executive officer or the COO of our trauma hospital in southern Kandahar, Role 3 Trauma Hospital, which is in the southern part of the country. And so in 2017, I did that for 6 months. That went well. Came back and they said, hey, we need a CMO for Balboa Naval Hospital. So I was lucky enough to get that opportunity. And then my last year and a half in the Navy was as the CMO of the Pacific. So all the hospitals west of the Mississippi, and actually they all worked directly for their CO, but we had a consortium of CMOs that worked around the Pacific, and that was right around COVID. So that was the beginning of COVID, was my last year in the Navy. And then when I retired, there was an opportunity to come be the CMO at First Hill. So in Swedish system, a CMO at First Hill, it's like 700 licensed bed hospital. And of course. So we moved my family up here. My kids were both in high school, so they still are thankful for me doing that to them. Sarcasm. And then from there, it's just grew. And so now we've got oversee 4 hospitals and 1 standalone ED in the King County area.
When you had the Pacific responsibility, how many facilities or how many beds did that involve, roughly?
Good grief, I forget the bed count. I think it's 12 hospitals.
Okay.
And it's interesting because they're international too. So, and each one of those hospitals in the military has a specific designated job. Like if you're Okinawa, your place in the world, like what that CMO for that hospital is unique compared to Bremerton, so they all have a mission. They're responsible to their direct commanding officer at that place. So for me, the challenge was, hey, what are you going through that I don't understand because I've never worked there, and how can I help you? And then it happened to be the same time COVID broke out, so that question got a lot more intense. But
yeah, okay, fascinating. And while these stepwise progressions were occurring through the hierarchy and the scope in the Navy, up until and even with the current role at Providence, were you doing things to continue to prepare yourself, perpetually prepare? What were you doing or not doing or learning? And I'm really specific. I want to let our listeners know, how do people prepare to become or be a better chief medical officer?
That's a great, I read that's a question I think has got a lot of, there's 1,000 different ways to do it, right? Like, it's like when it's even, Lee, like if you asked 10 CMOs what they do, you're going to get 10 different answers. Because I think depending on the hospital you're at, the payer mix, the type of hospital, you're going to see their jobs are slightly different. We're a lot of quality safety, but I think for me it was being open to every time I was in a new situation, just learning as much as I could. Like you can go get degrees and stuff, but really sponging up as much as you can. So my time in the branch clinics, understanding HEDIS and third next available and what it's like for the hospital to be the person sending us work instead of, wondering why they're not seeing our patients, and being able to, what is the way to get more access for mammography in a clinic, or how important dental is to your world. I just think every time you're in like in Kandahar, like having the facilities piece, like all of a sudden, like you don't need me to be a doctor, but hey, Chris, we're having difficulty with our sterilizers, and we're the only trauma hospital in the southern half of in a war zone. Luckily, we were able to get out of some tight spots. But hey, what do you do when you have a facilities issue? I'm learning how facilities work and how different folks, how you solve a problem in those different areas, and I think that was, and then keeping people's the OJT of keeping people's morale up, or at least trying to keep people's morale up in the middle of these very difficult times. I think anybody who's been in any kind of administrative or leadership role through COVID can relate to that, which is, we got a tough job to do. How do I get you to still be happy coming to work?
Yes, the on-the-job training, and a couple of our guests have reflected on that, and that has to be one of the most important preparatory skills that a chief medical officer will use. And there is nothing better than going down to SPD where your sterilization is, or going, and some of our folks are not emergency room physicians, never trained in the emergency room, and they don't know how it works. So you got to go down there and watch it and listen and learn. And fortunately, because of our education and our residency, we are capable of looking at processes, using sterilization as an example, and coming up with solutions. We're trained for that. It's not like we just went off to become an accountant and a healthcare administrator. We actually understand what's going on. And I cannot emphasize enough that if you feel like you don't know something, then be humble and go learn about it. And you will be able to learn about it. And that is part of our responsibility as a chief medical officer, right?
No, I love your point there. And I guess the thing that I would emphasize too is that any crisis that you're putting out is, if you don't already understand it, is a great opportunity to learn. And it also helps you. So as the chief medical officer, if somebody's having a problem and you take the time to go learn it, you're building political capital that you can spend later on something else that you might need. But the fact that you cared enough to see what their workspace looked like, I think it's the perfect mix of, you're learning, you got to solve the problem anyways. And you get buy-in from the team, the frontline people. So
most of the time they know the answer. They're just looking for somebody to grant them the authority or break down the barrier to get it done. And so I totally agree with you. Okay. So, all right. So we understand how you got there. And as you look at what you've accomplished, and you have a successful career, and hopefully for many more years to come.
Yeah. So let's cross our fingers on
that. Step back and consider the following. If I were to have gone to any of the naval bases or your current workplace and speak to your coworkers, how might they describe you to me? What do you think they observe about you?
It would be, the interesting study would be for me to tell you this, and then you go find out.
Yeah.
So
well, I booked my plane ticket a long time ago, so we're going to find out.
What I think and what they think might be different. My hope would be that they, optimism, good listener, and a cheerleader. I've been called a cheerleader a lot, and it used to frustrate me. I'm like, I'm more than a cheerleader. I'm actually helping solve problems. Like I actually help solve problems, right? And then I realized it was, we do so much of our work as CMO is influence, right? And there's tons of books and people's experience too, like how much you can get out of people when you're admonishing, and how much you can get out of them when you're praising. And I think So the cheerleader thing has grown on me. It's not like at first I'm like, I actually do something. I don't just root for you, but it's a title that I've grown to appreciate, and listening. And I think being optimistic, there's plenty of pessimism out there. Find a way to be optimistic. And I hope people see me as optimistic.
I love everything that you said, and I'll find out when I land in Seattle and get to the hospital.
Well, if you tell me who it is, I can lay some money out first and see if we can get through that.
But listen. So I was handed case management in the midst of my career. Do you oversee case management? Is that your scope of responsibility?
I wouldn't say directly, but I spent a lot of time like I was working with. They call me in for everything.
Yes,
so.
And that is a natural thing, and like the so-called dotted line or other duties as assigned, and they see you as a partner in the work that needs to get done. Well, so I was handed case management because nobody else could seem to figure out why case management struggled. And I will share with you that I too, although didn't realize it until about 3.5 minutes ago, I was a cheerleader too. But what I was doing, not realizing it, was I had their back. And sometimes leadership is having somebody's back so that they feel that they can go ahead and do something that otherwise they might have been reluctant, scared, unsure. And when a physician has another clinical worker, like a social worker or a case manager who has got a nursing background or a social work degree, when a physician is behind them, man, it is almost unfettered power for them. And it is great. And things happen because they can say, well, Dr. Scheinbart said, or what, maybe you should go talk to Dr. Scheinbart. Before then, they would be like, oh, okay, sorry, Dr. Ross. Sorry, Dr. Thompson. You're right. We're not going to discharge Johnny today, right? Oh, well. So I think being a cheerleader is something of great. You should be very proud if that's what they say when I arrive. That'll be great.
Well, and I think your point's well made too. Like it is I think it empowers people because then you kind of say, look, you feel free to tell them that we had this conversation. Yep. And I think what you're doing is great work. And, I tend to think that most people, physicians, APCs, and all of our caregivers, they're all trying to do the right thing. I think we all come with, our own bent as to what that looks like and really, getting people to feel like they can have the conversation where they find the common ground is kind of what we do.
Yeah. It's almost never the what, it's always the how. And it's always with good intent 99% of the time. And we just need to work through the how part. So, so would your wife and kids say you're also a cheerleader at home?
I think they're still within a few years of moving to Seattle. So they seem to be doing better, but, no, they're good kids, and we have a great family, and I think they I did a CMO thing with my kids. I'm like, look, let's just look at the facts. I know you don't want to do this, but it's the right thing to do. We need to do it. Financially, we don't have a lot of other options right now, and so it was a CMO talk, and they're like, yeah, we're not thrilled. At our family board meeting, we're not thrilled, but the move makes sense. I think we can do that.
I think your consensus building ranks way up there, and the use of influence in the power dynamics are wonderful.
Well, because I've lost to them on so many other arguments. I had use a little of my political clout. Like, remember when I let you get away with this or that?
Okay. So, all right, we got the construct, how you got there, things that were of high value and what people would say. Was there any person or persons who was particularly influential to you in this preparation? Are there any role models? And you don't have to name names, but you could describe them to our listeners.
Yeah, I appreciate this. So, I think it's interesting. You learn from people who are good and people who are not good. So I had some leaders who I'm like, I can see how this is, and they meant well, right? Like I can be thankful that I don't think I had any truly nefarious people that I followed. I did have some people who probably didn't come across or weren't as effective as they thought they were because of the way they did it. So in that sense, I learned from some of my leaders that way. And then some of the folks that I learned the most from, I had a string of female XOs and COs that were really good at managing tough situations. And I didn't realize it till, and actually my boss now is Dr. Waco, Elizabeth Waco. It's just have a command of the room that I always admired. And I think I don't know why that is, but I think the female leadership part is kind of, there's three or four folks in a row. Like it just was, and it just happened. But I've been really impressed. I think the style that these women used to manage situations was a little different, as far as being patient, firm, and focused, and really try and emulate that, as far as when I think back of the leaders that I had. And then, it's not just those folks, but I think as I look back over the past 5 to 10 years, I think those 3 or 4 folks really had the most influence, including Elizabeth, who's my current boss.
That is really important, and maybe a full topic for another show. I was embarrassed when I realized that it had taken me weeks to interview a woman chief medical officer, because more than 50% of the students in medical school are women. And it began probably back when you and I were in school, that trend to open the experience of who students can and should be. And they're great leaders. And we don't have enough women chief medical officers, and we surely don't have enough women physician CEOs. Only about 5 to 6% of hospital-based health systems are physicians, and I can't even begin to guess how few of them are women. And they bring exactly what you describe, a different set of management skills that might be both innate and learned, that are a great balance for those of us who have had different role models, and we can role model for each other, and the dynamic that presents is all for the benefit of the healthcare and the patients. I am absolutely convinced of that.
I am too, and I guess it's just kind of gelled recently that, because somebody at that convention we were just at, that event we were just at, is a female CMO leader in actually a nearby area. They're thinking of writing a book about the role of women in healthcare executive leadership, and I'm like, call me. I'm like, huge impact on my career, and they probably will never know how much they've affected my career, but I'll hopefully reach back out and let them know. But no, not that I'm not saying one's better or worse. It's just, man, it's a different way of seeing things, and it's been eye opening.
Yes, and I think the House of Medicine is evolving, and one of my hopes is that, so there was the archetype of the physician in the 50s and 60s. It was the same person again and again, invited to enter medical school to become a physician. And we have so thankfully moved from those very narrow personality types to taking all kinds of people with perspectives by which we're better for it. Absolutely. What was the hardest thing so far that you have faced as a CMO, aside from the pandemic? Can you tell us anything about that?
Yeah, this is one where I will not name the facility, but and I will not name the organization that was doing the review. But let's just say we were getting a review, and it was a big one, and we were about to crush it. Like, we were 3 days into a 5-day review, and I had gotten the message that we're going to finish it early. Things are going so well, we're going to finish it early. I literally have the microphone in my hand and getting ready to talk, and somebody taps me on the shoulder. I'm like, what's going on? And they're like, it's unraveling in such and such clinic. I'm like, what? So I said, everybody, because we had an auditorium full of people. I said, just hold on a second. Let me go find out. So we had, I guess I could say this. We had not before been looked at for dental. Like, dental was now on the agenda, and it had not been in the past. And God love my dentist, but the concept that the mouth is not a sterile place is not a discussion topic that anybody in an accreditation body wants to hear. And you can only imagine how the answers, like, these are truthful answers, and they're not wrong. But if you have not gone through being accredited before, and it's a bit of a dance. Like they're asking you a question. This is what they're trying to get at.
Right.
But if you've never done the dance and you're just giving straight, honest answers, you're not wrong, but you're not right. And so that thing just came unglued, and we spent 6 months trying to solve that problem. I will say it was also probably one of the highlights, because at the end of the 6 months, we were not just audit ready. We were top rated. We got a lot of kudos for the work that went into that. But man, that was a tough 6 months, because basically we had to explain to a whole service line how these accreditation things go and what you need to do and the standards that are set. They were actually probably meeting most of the standards, and the stuff that they're like, well, that doesn't make sense. We shouldn't have to do that. I'm like, there's 90% that you should do. Then there's 10% where I don't really care whether you think you should do it or not. We're doing it because somebody somewhere told this group that we need to do it. So let's do it. I didn't say it exactly like that, but you get my point. Like anybody who's been through these reviews, you know what I'm talking about.
Yeah.
Both sides were right, but
it is, we had one reviewer at one of our institutions say, look, here's how this is going to go today. Well, I should preface with a remarkable story. So at a different facility where I was also a physician executive, first time CEO of the facility, first time receiving a Joint Commission survey for the entire facility. And the surveyors gave the CEO, like, would you like to make any opening remarks, sir? And he says, absolutely. This is going to be the first hospital that you ever survey where you will find 0 findings. 0. I promise you. I couldn't get under that desk fast enough.
oh.
And they were calm, cool, collected. They were like, well, thank you, Mr. So-and-so. And they turned to the next person and make sure we all got our introductions and everybody had a chance to say something like, very excited to have you here. I hope I learn a lot from you. I hope you show me things that I wasn't thinking about and prepare me for the next survey. Like that's
right. Somebody who knows what to say. It's like you don't say, hey, it looks like things are quiet in the ER.
Yeah.
These are just things you don't say.
So this is at a time when Joint Commission was shifting to their so-called safer matrix. And they give you their rundown at the end of each day. And so it was a little bit different. And a lot of our older people had not been used to the safer matrix. So stuff starts showing up in the upper right, super red, crimson quadrant. And I'm like, I turned to my boss. I'm like, there are findings. We didn't hit 0. And he didn't quite understand. And so we crawled through that. So I feel your pain, and I'm getting a little PTSD about it. So we can move on from.
Well, but it's funny because we talked about it before, right? Like that's a crisis where that CO, and then in my situation, we all were better because of it. So yes. I kind of changed my whole opinion on the accreditation thing. Was that, there were things we needed to tighten up. We weren't crazy off the rails, but I think the learning experience, good grief, I can tell you how many water spots a dental instrument should be when you look up at the light.
Yeah.
Like stuff that you would never have known before.
Have you ever looked up inside the water and ice dispenser in the little, break area, or what you're serving your patients when they want a glass of water? It's disgusting. And Joint Commission will look inside that to make sure that it is not. Anyway. All right. So what was the biggest fire that you had to put out, rush to deal with, again, aside from COVID-19, and hopefully you were able to calm the flames? Anything come to mind?
I think that the biggest fire that it was recently. It was I'm sure you went through it. Remember when the computers all went down? I'm trying to remember what the name of that thing was.
So we had the Change Healthcare last year, the year before.
Yeah, like last fall.
Yeah.
So I was on. We have a medical officer of the day, a mood. So the doc, and that happened to be on that night. And Epic's down. I'm like, okay, that always happens. And it was like at 1 a.m. I'm like, seriously, call me at 2. And if it's not back up again, and they're like, no, I think this is a big deal. I'm like, I don't know. It's always a big deal. Go to downtime precautions and stuff like that. 2:30 rolls around. They're like, Chris, we told you this was I'm like, all right. So we start firing it up. And then that thing went on and on and on. And I have, again, sometimes in these crisis situations, I think so. My role was come up with a cadence, a way to look at the problem, and then get the subject matter experts in there so that we're asking the same questions in a rhythm and a time and a way. So that was my role. What was impressive was the people the subject matter experts that actually stepped up and solved it. And we had multiple really bright. I mean, as difficult as that was, hey, we don't have enough people over the weekend to come work on the IT piece. Volunteers showed up. Triple the number of people normally on. People volunteered to show up. Hey, those folks couldn't get to. Let's say they needed to get to 100 computers. They got to like 250. We still don't have enough. Oh, don't worry. The team that comes in Monday has already figured out how to do the troubleshooting by watching the other people do it. And they've already got their computers up and running in their own clinics and stuff we didn't even ask people to do. So I guess I can't really say that I put the fire out. My job was to, remain calm and look, find your exits, but but I think sometimes as a CMO, as a cheerleader, your job is, hey, let me help just build a framework that we can have people fill in with their subject matter expertise. And I think, and then I went for like 24 hours straight. So I had to hand off at some point to somebody else doing it. But all of our leaders that stepped in did a phenomenal job. And then all of our frontline caregivers really stepped up, and we had a disruption, but it could have been so much worse.
But I think what you highlight is one of the most important leadership tools that, and I get on my soapbox about this, but it's something because I think that the vast majority of non-physician leaders, they don't understand. You are an emergency medicine trained physician. You actually have extra training in cardiovascular emergencies. The first thing you do is check your own pulse, and you bring calm into the chaos. That is a leader tool, and it is drilled into you as a physician, and it is irreplaceable. And if not trained in it, things could go really bad really quickly. So you clearly have great people around you, but you didn't have to micromanage what they needed to do. You needed to show them the exit or the map, or this is where we have got to get to by tonight or by tomorrow. And they exceeded your expectation. The leader responsibility of calm into chaos cannot be understated, and it's specifically that physicians are trained to deal with it. And I don't care whether you're an emergency medicine physician or an obstetrician or a pediatrician. At some point in your training, you went through this notion of how to do it, and which is why I want to advocate for more women in medicine, in leadership roles, more CMOs become CEOs, so on and so forth. But that's aspirational, and we won't accomplish that on the podcast. But your insights are spot on, and I agree with you. What's the hardest aspect for you personally of being a chief medical officer, of the job, the role, the work that you do? What's the hardest thing for you?
Yeah, that's the one that I think it's lack of control. So when you're, I can only speak for my specialty, but I'd walk into a shift. I had 8 to 12 beds and phenomenal staff, and I knew what was going on each one of those. I knew when they were coming, when they were going, and what our map was, and I could personally drive that. Not by myself, but as a team, we could drive to a solution. As a CMO, we're part of everything, but we are directly owners of very few things, like even the quality safety, which is our calling card, right? Like CMOs are quality safety, but nurses run the floors. Like we are tenants on their turf. So quality safety is part of melding with that team. And so you have to kind of influence. And I think in many ways it's great to be doing get to be an opinion on everything. But in some ways it's frustrating because you also have to because if the team succeeds, you have to be part of the success. You get to be part of the success, but not as. But then when it doesn't succeed, you're also part of that. Because and so I think the control piece of, there are things that if I could just tell people what to do and they would do it. But quite honestly, I've also learned that if in the instances where I just get to tell people what to do, it doesn't always go well either.
Mm-hmm,
So
mm-hmm.
I think the matrix part of being a CMO is the most frustrating and probably the best thing too. Like you have to learn how to draw the best out of others, and not be completely self-sufficient and do it all yourself. But then the flip side is you are not self-sufficient and you can't do everything yourself. Yeah.
And listen, Chris, I appreciate you opening up about that, because you're speaking from the heart. It comes across loud and clear, but it's also to the point about physician readiness and physician training in a crisis, small, medium, big. Because we are trained to be autonomous actors in an ambiguous world of illness, disease, social circumstances. Somebody rolls in off the rig, on the gurney, in front of you, not able to verbalize. There's a lot of ambiguity there. And you are trained to take total ownership and total control of something that is otherwise, for the average person, completely beyond their skill set. And so when we walk into an executive role, what do we find out in our first meeting? We don't have any control. We don't know anything. We don't have any authority. And these guys and gals have 25 years on us about consensus building, like your family boardroom meeting. Let's map this out. Let's look at the pros and cons. The doctor doesn't have time with that unconscious patient to stand back. Well, how do we all see this? And do we all agree there's a patient on the gurney? Like, we can't do that. But as a physician executive, that may be one of the hardest challenges to learn in the role and watch other people's modeled behavior so we can adapt to that. What do you think about that?
I think you're spot on. And I would add to it too, that our docs and APCs expect us to do that because they know that they can't be in the room. And so what I've learned is they don't want me to go in, demand it be my way, and fail. I'll hear, I'm glad you go to those meetings because I couldn't take it. And what I hear from that is, if I'm going to go in there and throw a fit, Chris, I need you to go in there and be more diplomatic. And so I'm like, so in my heart, I want to throw a fit, but I know that they don't really want me to come do that. They want me to come in and be diplomatic and try and use the matrix to win hearts and minds.
Yeah.
And so it's our calling, but it's not easy because you're right. Our training is clear the room. I got this. I've got algorithms that if you follow me, we're going to be fine. They're like, we got our own algorithms. This is not.
Yeah. Well done. What would you say? Would you go back to your younger self and mention the notion of letting go of control? Are there other things you might say to your younger self?
Well, there's so many things I would tell me. I mean,
okay, we'll put that for the next show.
Well, as I look back over my career, like I self-imploded because of my own personality, like every 4 years, almost like Old Faithful, like I'm going to do something dumb, and it's only because I wasn't patient. I expected more. I misread other people. And I think the one thing I would tell my younger self is, it's not necessarily what you're in your mind, what you've built this to be. It might not be that. It might. So it's okay to plan for it, but don't bank on your inference of what other people are thinking or doing is exactly you can't ascribe everything. I'm not right all the time. So let it play out a little bit. Don't act before you're sure unless you need to. And I think patience and humility are things that good grief, I keep learning. I don't want to learn anymore, but I can't help myself. I just keep doing stupid stuff and being like, I knew I should have been listening instead of talking. I knew I should have been hearing instead of directing. And I think listening more and talking less is something I still need to do.
Yeah. Well, the humility of you saying that on this show is also another leader lesson. So kudos to you for recognizing that and telling it to your younger self. All right, we're getting down to a couple more questions here. Maybe I think the doctor shortage may be one of the single worst problems, it is not receiving the right attention, and we're using the wrong solutions. And one thing I've begun to consider and share, and I want your opinion on this, please, maybe we need to rethink what is doctoring. What is the role of the doctor? And if we understand that, and if AI is a tool like a stethoscope to help me look at an ECG or look for that stroke, if it's a type of modality to make us better at our skills, fine. But if it cleans up the garbage, maybe we shouldn't have the garbage in the first place and allow the doctoring to occur. So, any thoughts on the matter?
I think you're right. I think doctoring is going to have to change. And part of that, as you were speaking, it was kind of clicking with me, but, patient's expectation. So I think we're not going to, the fact that we won't have as many doctors and APCs around to cover the call and to be that in person, that's going to happen whether we want it or not. How do we get the patients and the people that we care about? And we all care deeply about our patient populations. How do we prepare them for the difference in what healthcare is going to be? Because there just won't be, there's going to have to be some AI. There's going to have to be less in person. There's going to have to be more virtual visits just by the nature of it. And their expectation of that is something that I worry about too. And it hit me when you were saying it, is that the doctoring will change, but I don't know that we have an option. Like if you've got 2 docs for 5 hospitals to cover call, then you're going to have 2 docs covering 5 hospitals. The patient experience is going to be different. How do we prepare them?
Yeah. Yes. And having the old strategies, but see more patients really doesn't solve anything. So yeah,
we get less doctors that way. Well, honestly, yeah. I'm more worried about retention. Like I've got doctors that'll come out and tell me that it's not about necessarily the money, it's the lifestyle. So the fact that we're adding on more hospitals for coverage, that is not a selling point. And, my biggest worry is attrition at this point. Yeah. I'm not even trying to get new. It's just losing the ones we got.
Yeah. Yeah. Well, you are well equipped. You have excellent leadership skills. We teach this at AAPL, and you're hitting on all cylinders. So I want to be your cheerleader. I got your back. You're doing a great thing for the people in your community. And we need more physician leaders to continue to think about doctoring and looking at some of the real problems. That's the dumpster fire of healthcare today. Being a chief medical officer is just like being a firefighter. That's what my old boss used to tell me all the time when I complained about the things that I complained about. He said, look, you got to start by going to firefighting school. You got to train. You got to keep training. You'll drill. You put on that uniform. You go out and fight that fire just like you did as a medical student. Put on that white coat and go out and learn how to take care of a patient. And then one day somebody says, maybe you should be the squad leader or the captain of the firehouse, maybe the fire chief. And my boss told me, you'll never be a fire chief without first becoming a firefighter. Would you agree with that?
100%. I love that analogy. It's great.
It's why it's called the Fire Chief
That's
Podcast,
right.
The only show dedicated to the chief medical officer. And that's what you have been listening to. And if you want to learn more about what it is like to be a CMO, if you want to be on the show, email me at leescheinbart@gmail.com or connect with me on LinkedIn. You can listen to the podcast on Apple and on Spotify, and you can watch the shows on YouTube. Our show's website is thefirechief.podbean.com. I love talking with CMOs from all over the United States. So please connect, leave your reviews and comments, and please share this with your colleagues. And in the words of Sergeant Phil Esterhaus, let's be careful out there today.